Guys, welcome to today's live session. We are going to be talking about anterior pelvic tilt, fixing it. If you've got that increased curve in the lower back, your pelvis is going forwards, we're going to be talking through what's happening, how it's going to be diagnosed, and ultimately what we can do to fix it. And this is part of our series where we are exploring exercises, strategies, diagnoses, etc. that you guys struggling with lower back pain and sciatica might have been given by other practitioners to help you understand maybe their thinking behind that. And then we're going to go through a critique of these scenarios. And in today's live session, I'll share it quickly on the screen. We're going to be going through an x-ray example as well to show you guys. We're going to be talking about numbers. That should be really insightful. This is x-rays of one of the members. So we're going to go through a bit of analysis there as well. Should be very helpful. Now, before I get into this quickly, I just wanted to share something. If you are watching right now and you are one of the members of the Back in Shape program, definitely head over to the Facebook group and have a look at one of the posts that was shared the other day. The reason, literally yesterday, sorry. And the reason I want to point you guys to this is because we've got one of the members sharing her MRI results and a bit of chat about the conversations that she had with her surgeon. The MRI results are 2 years apart, sorry, 1 year apart. And she's just talking about the clear reality of the improvement visually of that herniated disc, the shock of the surgeon, the fact that she's doing running on a bi-weekly basis, well, bi-weekly with regards to the park run and on the treadmill. She's in the gym doing squats with significant amounts of loading. And I say this all to say, sometimes people get the wrong impression. They get told somewhere that your discs don't heal, that the herniated discs can't get stronger, that the injuries of your back are going to be there forever. And it's just simply not the case. And this is just a really cool example that she shared. You can read a bit of the commentary in there if you're one of the members. And it should be really encouraging for you. And Rach specifically, her diagnosis, we're talking about an L5-S1 disc herniation in that example that I literally just mentioned. Okay. So everything we talk about in the program, all of the comments that we talk about in terms of the way in which we structure the rehab, talk about the neutral spine, building resilience through strength-based exercises to help us recover from these kind of herniated discs in the lower back. It's all good stuff. And there's a great example very recently, as I've mentioned, in the group there in black and white with the MRIs, with the before and after, and it's so cool. So just wanted to touch on that first. Now, back to the topic of anterior pelvic tilt. This is what we're going to be talking about today because it's something that gets talked about all too frequently. And let's start off with actually defining what anterior pelvic tilt is. Why does this even matter? Why is this something that your physiotherapist, your osteopath, your chiropractor might even be looking into? And what we need to understand with regards to the spine is there is an alignment that it should ideally have, that us as normal human beings should have. And you have to understand that you and I, we should make the assumption that we have normal alignment. And I kind of hit that point home time and time again, unless proven otherwise. And so the structure of the L5-S1 in particular is such that the disc here is a little bit of a wedge shape. And that's to provide a little bit of support. But what we should have in a normal, healthy lumbar spine is we've got a nice curve. Even if we've got a herniation, even if we've got degenerative discs, etc., we should have a nice, normal curve. This curve is called the lordosis. Lordosis means that it bends backwards. And the pelvis has a degree of tilt to it, we could say. We could say this is just the neutral position of the pelvis, and then it will tilt backwards in posterior tilt or forwards into anterior tilt. But why anterior tilt is an issue is because there should be a slope to this sacrum. The base of the sacrum sits like so, and then the disc sits on top of it, and then so on and so forth. And if I remove the spine for a second and just use one of these little blocks, the slope should be like that, okay? Around about 40 degrees. We're going to talk about that in more detail when we go through the images just over here a little bit later on. Numbers, okay? But what we are saying in the anterior pelvic tilt is that you're actually tilted like this. And this creates a lot more shear. It creates shear forces at the level of the L5-S1 in particular. What we also often get in the scenarios of an actual anterior pelvic tilt, where we are tilting forwards, is we then get instead of just bending forwards, we then arch our lower back to actually stand up straight. And that compresses the facet joints. It closes the little holes where the nerves come out. It creates other unintended consequences as well. So we don't want to have anterior pelvic tilt when we are standing in the upright position. That's fairly accepted, I would suggest. We're supposed to be in a normal position, and too much anterior pelvic tilt is going to be unhelpful, and too much posterior pelvic tilt is also going to be unhelpful. And Rachel, I would definitely stick around for the x-ray review when we get to that, because The person that we are reviewing on the x-rays, the member that we are reviewing on the x-rays, was also told they had anterior pelvic tilt and was also told that they have too much curve in the lower back. Admittedly, the curve was, the statement was you might have a little bit too much curve, or no, you do have a little bit too much curve, but very, very important. It's something we hear time and time again. And so why is this happening? Why might this be happening? What's the hypothesis? Well, many people will talk about the hypothesis, and certain practitioners will have their own skews on this, but it is perhaps suggested that because we are sitting all day in this position with the hip at 90 degrees, okay, that the hip flexors are tightening up such that when we go and stand up, we're stuck in this position, so we arch our back and walk around like a duck, right? That is maybe one of the hypotheses here, that because we do spend so much time sitting, that is what's happening. That assumes fundamentally a normal, good, healthy sitting posture. And we can talk a little bit about that again. And guys, Nima, if you stick around, because we're going to be talking specifically about the alignment of the spine very shortly with an example. And so how does your anterior pelvic tilt get diagnosed? Well, we make the statement that, you know what, many of you guys will have been there. Maybe Nima, maybe Rach has been told this when she got her anterior pelvic tilt. You're standing there and they say, oh, look, your bum's sticking out. Oh, look, your tummy's sticking out. That's because you're anterior pelvic tilted. And oh, look, your back's nice and deep here. And so yeah, I can see that. I can see how that might happen, right? I can see how that might happen when I move the spine, right? Oh, look, the bum's sticking out. Oh, look, the back's arched too much. And oh, look, my tummy's going to stick out here. Fair enough, right? We can get on board with all of that. And so what do I do to fix this? Very, very easy, right? Everything's going forwards. So I just go backwards. Problem solved, right? But if you do that, you realize, you know, I'm actually not getting better. This isn't actually working. I'm doing pelvic tilts, I'm doing knee hugs, I'm doing child's pose, all the same old stuff. And so then we get to the critique. This is hopefully helps you guys understand, like, that's the thought process and the examination process that goes into this. And one final thing that I forgot to mention in that is that we talk about the posterior PSISs, posterior superior iliac spine, bit of a mouthful, and the anterior superior iliac spine. And sometimes we'll put our hands on, or the clinician, the osteopath, the chiro, the physio, will put their hands on those bits and go, look, it's an anterior pelvic tilt, posterior, anterior, right? And they'll talk about all of that. But now let's go through the assumptions, because there's so much flawed in this. Anterior pelvic tilt is a real thing, right? It is a real thing. It's a measurable thing. But you notice in all of these scenarios, there is no mention of any numbers. It's anterior pelvic tilted. And so the first thing is the observation to start. I think the simple reality for so many people who have been diagnosed with anterior pelvic tilt, but the general population anyway, is that we don't sit nice and upright. Most of us are actually sat in a slouched position all day. And so the hips aren't actually in that much of a flexed position all day. They're not like this all day, flexed up to 90 degrees. They might be at like 60 or 70 or 80 degrees, and we're sat like this on the computer for hours, right? That's not a hip at 90 degrees. That's a hip at maybe somewhere in the region of, you know, 120, 180 degrees, 160 degrees, something like that. And as we slouch down the chair through the course of the day, or used to anyway, that hip angle gets arguably less flexed. And so I think the fundamental observations in many cases of people, or the hypothesis of people being sat in this very upright position, stuck in a flexed position, is really quite off. It's quite wrong. It's just a misunderstanding. And then we get to some of the testing. Thomas test might be one. Okay, if we are hypothesizing that we actually have a flexion in the lumbar spine, or rather not a flexion at the hip, because the hip flexors are pulling that lumbar spine into the anterior pelvic tilt. Your psoas muscle, for example, plugs into here. It pulls, in the cases of the anterior pelvic tilt, it's pulling you into that position forwards. And so we might do Thomas test. Thomas test is where we hug one knee and we lie backwards. Okay? And we had a specific example of this with one of the members. Now, we'd actually seen her x-ray. She had a reduced lumbar curve and a posterior pelvic tilt. And Thomas test looked positive. And I'm going to draw an example to help you guys understand this. But the orientation of the pelvis when you perform a Thomas test could potentially be that it gives you a positive Thomas test with the leg floating, when actually you do not have that positive test. Actually, there's nothing wrong with the hip orientation. And to see this in action a little bit more clearly, we need to look at shoulder mechanics. The flexion at the shoulder should come up like so, above your shoulder, right? Good flexion. If I slouch terribly through my thoracic spine and then move through there, I am not in the same position as here. So the orientation of where the shoulder joint is in space when I start my test matters to how we might perceive the result of the test, the outcome of the test. Well, if when I'm doing Thomas test, which I will try and demonstrate it to you guys actually, just here, right? If I'm doing a massive posterior pelvic tilt in this position and then let my leg drop, it might just be floating up here. And if I was to support the normal alignment of the lumbar spine, now all of a sudden it goes to the right place. Yes, we are supposed to block and hug the knee to stop the lumbar spine from moving, to isolate hip extension. But what if we're already stuck in a significantly flexed position? That's something to consider. That affects the total amount of extension at the level of the hip. So that could be a flawed metric, a flawed evaluation tool. And then we get to the biggest problem of all, and that is the physical evaluation component of all of this. Actually looking at the person, and we'll see this on the x-rays in a moment, why this is such a flaw. You have no clue. I can make my tummy stick out and I can draw it in, and my spine hasn't changed at all. My buttocks are not over my spine. They are over the kyphosis of the sacrum. So comments about this are comments about the sacral kyphosis, not comments about the lumbar lordosis. These are very important flaws in all of this. And then the comment of the spinous processes themselves, which we'll see on the x-ray in a second. They are on the very edge. That's all you're seeing of the alignment of the lumbar spine to suggest that we can see this, and we are going to make the claim that we have an anterior pelvic tilt and a hyperlordosis, or too much curve in the lower back. You have no idea of the alignment. On top of that, when we are talking about the anterior pelvic tilt, we are not identifying a starting point. From the physical examinations, you're not referencing so often, the people that will diagnose these anterior pelvic tilts are not referencing a correct value, and they're not referencing how far away. It's just that you've got anterior pelvic tilt. So in the comment of fixing this with regards to the posterior pelvic tilt, for example, you have no idea of how far you should be posteriorly pelvic tilting. Is it 10 degrees, 15 degrees, 20 degrees, etc.? And so if we get into the x-ray now, bearing in mind this person was told by a qualified practitioner, I'm not sure 100% because I did ask them, but I didn't get an answer in time, whether this was an osteopath or physiotherapist or chiropractor. I'm going to assume it might well have actually been a chiropractor, which is, well, we'll get into that a little bit later on. But that is generally less, let's just say less forgivable, I would suggest, and less common that they would make this mistake. But let's share the images here so you guys know what we're looking at. So on here, we've got the normal x-ray, which is the standing position on the left-hand side. On the right-hand side, we have patient x-ray, the member x-ray. And I'll just make sure the pen's actually working so I can draw on here. I've put some yellow lines on here just for a few things that we want to talk about. But what you will see, this is a normal lumbar spine on the left-hand side. We have all of the blocks which are lining up along the green line. The green line represents the curve of the lumbar spine. Typically speaking, that's about a 40-degree curve. Okay, that curve is the normal position of our lumbar spine. We should also have a curve in the neck and a kyphosis, or a forward bending curve, in the rib cage and the sacrum. You can see the sacrum is actually curved forwards. That is a kyphosis. We don't change that because it's a fused bone. I digress. And you can see the slope of the sacrum here. That's that thing that we're interested in when we think about anterior pelvic tilt. If it was steep like this, it creates a lot more shearing. If it's flatter like this, it creates a lot more compression, right? It's designed to be just so. This is designed to have a wedge-shaped disc in it, slightly wedged compared to the others. And so that's how things are supposed to be. And then we've got what we also notice is the center of mass of the middle of the curve is directly over these yellow bits, which are the hips. So it's aligned well. Everything is aligned correctly. And you ask anyone who's got a lower back issue, the further you get away from alignment, away from vertical stacking of our centers of mass, the more we exert more strain through the whole system, often the hamstrings, the lower back muscles, the glutes, etc. And so when we circle back to the x-rays and we look at the image on this side here, bearing in mind this person is told they have too much curve, what should we see in the instance that we have too much curve? We should see a deeper measurement on the images. A deeper measurement on the images. What do we actually see? Well, when we look at these images here, we can measure that curve. It should be 40. It's a minus 40, meaning that it goes backwards. What we see on the image here is quite clearly, it doesn't take anyone with sophistication, I would argue, or prior knowledge, to see quite clearly that these bones make more of a curve than these bones that are numbered 1 through 5. Very, very clear. Now we measure it. It should be 40. And there is a slight caveat for this specific member. And I'll talk about that a little bit later on. But let's assuming just the normal. Okay. We should be 40. We measure the curve here at 15.4. Now you might ask, how are you measuring the curve? The curve is measured with something called tangent angles. Tangent angles are basically, you draw a line along the back of the vertebra and a line along the back of this vertebra, and that makes an angle here. And that's how we calculate the angle. You also do this for each of the individual vertebra as they stack one next to the other, next to the other, next to the other. That gives you a starting point. And then if you were doing range of motion testing, people talk about their spine being stiff or whatever the case may be, then you can actually get actual numbers on whether it is actually moving normally or whether it is not actually moving normally. And this is not to say that you need to do all of this, but it's to say that you as a practitioner or as a clinician should understand that this can be done and can be known, and what you typically find out from this sort of information, and also what can't be known from the physical examination. So what we see here is a qualified professional has suggested this person might have too much curve in the lower back, but it just so happens that they have 61% too little curve in their lumbar spine. Quite clearly, this spine is a lot straighter than it otherwise should be. Why? Because they've done physical examinations, because they've said, look, here's the sacrum, the bum is over here. Oh, look, that's a very deep slope there. That must be that there's too much curve in the lower back. Wrong. Wrong. Now, remove that there. Then we get to the pelvic tilt. Okay, well, what about a pelvic tilt? Because they've been told reliably that they've got an anterior pelvic tilt. Well, we look at this slope. Again, it doesn't take a genius. It just takes someone looking at comparisons to realize that that slope that I've just drawn on there compared to that slope, one is significantly steeper than the other. We can measure it again. A 36% reduction. This should be about 40 degrees. This is about 25.6. So we can see that there is a loss of 36% of tilt to the pelvis, meaning that not only was this patient diagnosed or told that they have an increased curve in their lower back and an anterior pelvic tilt, they don't have both of those things. And it's not that they don't have both of those things, but they actually have the inverse of what was established from a physical examination when we are talking in a measurable way. And Rachel said here, interesting, would you say you can't diagnose anterior pelvic tilt without an x-rays? Yes. An anterior pelvic tilt is not the problem. The problem is the injury to the lower back. Whether we had an anterior pelvic tilt or a posterior pelvic tilt, it doesn't matter. We most likely had this persuasion. I'll just come to me a second. We most likely had this persuasion before we were injured. This stuff doesn't change overnight. Yes, we can get antalgic postures. Yes, we can lean one way or the other. But we don't typically, like you cannot, and this is the biggest punchline here, assume you are a normal human being with an injured spine. That is the highest level of sophistication that you should have, unless you have evidence like this to suggest to the contrary. And then there's the kicker here, is that you're not even going to do anything different from a rehabilitation point of view in terms of the exercise and the rehab and the building strength and stability of your spine. You're not going to do anything different anyway. It doesn't change what you have to do from the rehabilitation point of view, because that's not how you change this stuff. So your best option is to provide stability to the area, nor do you need to, by the way, nor do you need to. These are important considerations, because too many people get these diagnoses. They get these diagnoses, they get told they've got anterior pelvic tilt, and they really lean into it. And they lean into it and start doing stuff. And you can imagine if this individual starts doing posterior pelvic tilting exercises, they're only going to make what's already a posterior pelvic tilt even worse. They're only going to compress the disc more. They're only going to stretch the spine out more, and they'll feel like they need to do more and more of these dead bugs. Not these dead bugs, sorry. They should be doing the dead bugs. They're going to feel like they need to do more and more of these pelvic tilts and more of these knee hugs and child's pose to try and fix the problem that actually isn't there. They're making the problem worse and consistently doing so because of the misguided initial examination. And so the biggest wisdom here is to know that you as a clinician, I know many of you guys are obviously not, you guys are people with back pain, injuries, herniated discs, etc. But the clinician needs to have the wisdom to know what they can't know from a physical examination. And if we are lucky enough to have the actual images here that we can talk about, then we can talk about those and actually talk about specifics. Now, there is one area that's interesting here, and that is that the L5S1 in particular is a little bit in an extended position. And that's generally, we see this here, 38 degrees, it should be 33. Okay, so it's a 15% increase. It's not a major increase, but it's there. The person is hinging back at the L5S1, probably because there's an injury at the L5S1 that's partially allowed it to do this, because they can't get the appropriate backward bending from their lumbar spine. So they're hinging at the LS. And from experience, you see this quite often, right? The person with a flattened lumbar spine and a posterior pelvic tilt will often have this pocket of extension in the midst of everything else, which is flexion. And the spine is actually bending forwards in the upper part of the lumbar spine as well. And so this just gives us better insight. Now, what are we going to do about all of this, right? We'll just add one caveat for you specifically watching this. The truth in this particular case is that, and we've discussed this on a couple of x-rays where relevant. I'll remove all of these drawings. There are some variations to this, okay? And based on the morphology of the individual's pelvis. So the relationship between the hip sockets and where they are, and the relationship between the sacrum does dictate how we might skew the interpretation of these measurements. And so for this particular individual, they don't really want to be shooting for a 40-degree curve. They want to be shooting for a 30-degree curve and a 30-degree sacral base. In spite of this, 15 is still low. And in spite of this, 25 is still low, although an awful lot more forgivable. We still need to understand, though, that they do not have an anterior pelvic tilt. They do not have too much curve in the lumbar spine. And those are the most important takeaways. Know what you can know from a physical exam and know what you can't know from a physical exam. And so one of the things, if I come back to me here, is that you're seeing a lot, and this is just from my experience talking to a couple of guys who've had exposure to the educational system inside of physio. One was an individual who was doing a master's in physiotherapy as an osteopath himself, and his observations. Another individual was a newly graduating chiropractor. In his experience, generally speaking, I would have always said over the years that chiropractors were less likely to make these kind of errors. But it seems as though the education system is moving more and more, and this probably lies into you guys' experience, right? The education system inside of the universities for osteopathy, chiropractic, physiotherapy are certainly moving more and more towards this biopsychosocial model. And it was something that was there in university when I was there. But it seems to be taking more of a hold, and such a hold that certain professors, certain lecturers, certain very experienced individuals who talk a lot about the structure are being kind of sidelined. And so it's highly likely that you guys have more likelihood of speaking to someone who doesn't actually subscribe to any of this, doesn't subscribe to the importance. And really, you just need to talk about your pain. And actually, pain is just in the brain. And really, there are people that have these kind of things that don't have any pain, so you should just talk yourself better, right? I'm being a bit hyperbolic in the characterization of that particular argument, but you're seeing it more and more because there's more and more chance that you're not going to get someone as a physio, a chiro, or an osteo who's helping you who actually has any awareness of what the spine even should look like. Yet they will still make proclamations about the anterior pelvic tilt or whatever it may be, the alignment of the spine. And so it's often from a position of just not knowing. And so I go back to that final point of assume, guys, if you have a lower back injury, you're not going to get routinely referred to for x-rays. You're not. I see that comment there from Zoe. She said, to get x-rays, is there an NHS route? Would you need to go private? What are the estimated costs? X-rays are relatively inexpensive. By comparison, you're talking about maybe for a set of lumbar images, you might be around about £120, maybe 150 now in certain areas of the country. And for a set of MRI imaging, you're going to be talking about maybe somewhere in the region of £300 to £400. Somewhere it's a little bit cheaper in certain places through like Vista and a couple of the other imaging centers. So that's cool, right? But this is one of the big reasons that I'm so much more for upright imaging. And of course, you have to bear in mind that having an X-ray is a dosage of radiation. Like you've got to bear that in mind. The equivalent to in terms of radiation for a lumbar X-ray is typically speaking around about the same amount of background radiation for 6 months that one might receive. Another example is for a cervical X-ray, a neck X-ray. It's somewhere in the region of the dosage that one might receive on a long haul flight to and from New York, from the UK. So you should discuss this, right? Renu has said here, chiropractor X-ray, said I have a very straight neck, less space and gaps at C5-6, impingement of the lower cervical nerve, giving me a stiff neck, etc. You're most likely, if you go to a chiropractor, to get given some element of X-rays on their standardized intake forms. That's probably the most reliable way of getting upright load-bearing imaging. But I want to circle back. In this particular case, we have a loss of lumbar lordosis. That we don't do anything about that right now, right? We don't need to do anything about that and get caught up on that. We make progress to the rehab, and the general consensus way in which we approach this is that if you do happen to, so firstly, assume you are a normal person that has a normal alignment, has a bad injury, or an injury that's been managed badly in the lower back. That might be a herniated disc, it might be this, it might be that, it might be the other, you might have sciatica, you might not, right? Assume you're normal. If you are lucky enough to have the evidence to suggest that you are not normal and you have some kind of malalignment, take note of it. Like, for example, the X-ray analysis that we've done today, right? We can see here that we've got a consideration of 30 degrees, but even in spite of the consideration, we're still a little bit flatter than we otherwise should be. Fairly obvious, given that you don't even need to be trained to see that that spine is straighter than it otherwise should be. And we've got a bit of a posterior pelvic tuck, right? It's straighter in the spine than it is posterior pelvic tuck, but that's our alignment. Know that, don't try and change it. Don't try and change it. Because who are you or I? I know what I'm trying to do in this particular case. But am I really specific enough to be able to anteriorly rotate my pelvis by 4 degrees? No, I'm not, right? Am I able to increase the curve of my lower back by 25 degrees? No, I'm not. Or 15 degrees, sorry. No, I'm not. So don't try and change it because you'll end up tying yourself in knots. The biggest problem is these people you guys get told you've got an anterior, you try and change it, but you don't even get told the reference point of where you should be aiming for and how much movement is done. And we don't measure how much movement you actually did. So it's just silliness. It's silliness. Don't try and change it. Focus instead on building your capacity, going through the rehabilitation, learning to stabilize what you have, right? It's important to know these things, but it's also important to stabilize what you have using exercises like the dead bug, the marching bridge, then building your load tolerance through the squat, the hip hinge, and step up, the single leg hip hinge, these exercises to build the load bearing capacity so you can protect this area more effectively. Now, one of the tools that we talk about that you can use to change this, but in a case like this, it's a little bit more difficult because we've got a couple of considerations to make. You can use things like the Denerol to lie over this. This is an enhancement of the towel. But in something like this, we have to also have knowledge of the limitations of us or you as a patient to be able to execute this exercise with the specificity that is required. So those are other considerations. And we have to play all that, mesh all that in together and say, in some cases, in many cases, don't worry about trying to change it. Support it better because it requires more support. Get stronger on your squat and hip hinge. Improve your levels of hip mobility. Stop trying to bend and twist your spine into the wrong direction, i.e. in this particular case, and for many of you, forward bending knee hugs, child's pose, etc., etc. Stop trying to do all of those things. Just focus on maintaining neutral spine and building that load tolerance. And then, where appropriate, we can look at doing some element of remodeling work. But it's not complex. It doesn't need to be costly, right? You can use one of those tools. If you use it for 20 minutes a day, the average person, considering certain variations in the level of degenerative change that's in the spine, can improve the rate of curve in the lumbar spine by about 25%, 10 degrees, in a 3 to 4 month period. Now, it's important to know that. Why is that relevant? Because are you saying just by stretching for 20 minutes a day, stretching the ligaments and remodeling the ligaments, over a 3 to 4 month period, we can change the alignment of our spine? Yes. What else are you doing every day that is stressing the ligaments, stretching the ligaments for periods of longer than 20 minutes every single day? Are we sat like this in bed, on our phone, not in bed, sorry, in the sofa every single day, stretching through here? I strongly suspect in this particular case, there's a lot of slouching that's going on because we saw there was a forward bending section at the upper part of the lumbar spine. Are we sat like this all day, slouching, stretching through those ligaments? Right? So, for minutes and minutes every single day, be more conscientious about our posture and the way in which we hold certain postures, because it does have an impact. It does have an impact. Develop better habits and we will do an awful lot better. What else have we got here? I will say as well, with reference to Rena's comment about the x-rays, you just from experience, like you see an awful lot more significant variation from the normal in the cervical spine than you do in the lumbar spine. It's very, very rare to see someone with a completely straight, i.e. 0 degree, so a straight line lumbar curve, but it's much more common to see what's called a military neck or even a kyphosis in the neck, a forward bending cervical spine. I think we've got smartphones to thank for that, unfortunately. Just look through some more of the comments here, guys. Over on YouTube, we've got BPX. I'll go through the comments on TikTok as well. And guys, if you're finding this helpful, do let us know in the comments. Sharing those X-rays. Thank you to the individual that shared these with us today. Hopefully it was helpful. If you do have any, I'm talking to you specifically now, if you do have any follow-up questions, please do post them in the group and we can continue the discussion there in more detail as well. Any specific implementation questions that you've got, please do ask. But guys, if you do find these helpful, please do let me know. Just looking at PBX says, I'm on 29th day after, I'm assuming, a micro discectomy, L4-5 and 5S1. What can I do? Please suggest me something. We need to be doing spine stabilization work. We need to be learning how to control and protect this spine. We've had a surgical procedure to a number of sections in the lower lumbar spine, and we need to learn to restore that ability to stabilize the spine. Renu says no images on nerves have been done by the chiro. No, they're making, the reason they're saying there's impingement on the nerves of on the cervical spine is because you have the symptoms to suggest that you have impingement of the nerves. So if you've got ridiculous symptoms down the arm, for example, tingling in your fingers, etc., depending on which nerves, C5-6, so this area, then it's obvious, right? That you've got irritation, impingement. Might use those terms perhaps interchangeably in the cervical spine. We don't need to have extra investigation to deduce that, although you might want to have an MRI. That's fair enough. Limit says Canon has made a fully standing full body MRI. It moved around your entire body. Yeah, the standing MRIs are cool, but like two things. Number one, I think they might be appropriate for a health orientated person who does not have an injury to do out of their own interest, right? There are also some really cool, it's called is it EOS? EOS system, I forget the exact name, and they do some really cool vertical upright imaging. There's a good center, Europe, forget the exact names, but anyway, but that's quite expensive to get that done. We're talking about, when I last looked into it, it was approaching £1,000, so it's probably a little bit more than that now. But the problem with the standing MRI for someone who's got a lower back issue is you can't stand, and you certainly can't stand still for the length of time necessary to go through that MRI, whereas the X-ray is extremely more accessible from a point of view of you stand there and we take a picture and it's done, right? And so that's where the trade-off, like, is it really viable, both in expense, to have the standing MRI? They do exist, but the quality again is not going to be as good as the lying down MRI, typically speaking, because of the limitations of the technology. So there's those things to consider. And if you think about who's referring you for the MRI, they don't really care about the stuff that I've talked about. The stuff that I've talked about with regards to the alignment is there to help you on the rehab front. It's there to help you understand your body better. That's not the job. The job of the MRI is to go, right, this patient's struggling, and I might be paraphrasing here, okay? But the job of the MRI, the reason you've been referred to the MRI from your GP or from your various medical practitioner is because we're saying, potentially, I want to know which bit is out so we can poke it with something sharp or remove it. That's the hypothesis there. Is there something we can poke with a needle? So they're not looking at it to glean this sort of information that I'm talking about here, to glean this understanding to educate you. They're just seeing if there's anything they can remove. That's the result is, if I get this result on the MRI, then I do this surgery, or then we carry on doing what we're doing. Right? That's the result. It's not, I'm going to use this MRI as a really helpful tool to help you understand your spine more. Right? That's not what these things are used for. And that may not be true, right? In certain scenarios, for example, if I'm referring a patient for an X-ray, if I'm referring for patients for an MRI, whatever it may be, I'm not just using it for that purpose. I'm using it for the purpose of helping me help explain and help that individual understand their own body better, right? Understand, why is it that L4-5 and L5S1 are the segments that are most degenerate, right? It's not just because you're old, because the whole spine is the same age. Why are those aging faster than the others? And then we can start to explore the things that you've done in your life, because you're not just a scan on a sheet of paper. You are a human being that exists in the world and does things, and maybe doesn't do some things that should be done, that are causing and contributing to what we see on the imaging in that snapshot. Just the same way as if I go in to get a snapshot blood test, right? And oh gosh, the number's blanking on me. The sugar test, HbA27, I think it is, or something like that. Levels are above normal. Okay, that indicates that you've got higher levels of sugar in your body over the past 3 months. It's measuring the amount of sugar, I think it is, on the blood, on the red blood cells. Okay, what does that mean? Well, if I then have the context of the fact that I'm, eating cookies every night, then I start to understand that there are things outside. That test means nothing on its own or means something on its own, but it means infinitely more if I can use it as a tool to educate the patient. And so maybe that bit's not missing. And of course, if you've only got a 5-minute conversation with your GP, you're realistically going to get that conversation. And that's not a slight at the GP. They're operating within the system that they've got, right? If you go to a private one, you might have a 20-minute, half-an-hour appointment. Okay, then you can have a better experience with that particular individual because they have the time and the constraints and the environment to be able to help you more effectively. HLA-B27. Nope, that's yeah. I'm getting hemoglobin A1C. There we are. There's so many numbers and things like that. It just, goodness me, terrible. Thanks, Jake. Glad someone's paying attention. Private 986 says, is the plank a good exercise to strengthen the core? No. Leave the plank out. Focus on your dead bugs, your marching bridges, your squats, your hip hinges, your step ups, single leg hip hinges. Joshua says, I have right abdomen and groin pain, and now back left, nerves in both legs, now 15 months on. Hopefully some of the stuff we've been talking about is helpful. Moshin says, would you say once the jelly has leaked out of the donut, it can come back in? No. And the body can do this to eradicate the part that's leaking out. So if you get the sequestration or the extrusion and the material, the nucleus material has actually straight out the back, then often the immune system will clear that up pretty good. The problem that you have is that you've lost the stuff in the middle. That stuff's not really going to regenerate very well at all, if at all, right? And so that now you're stuck with that height. That's not the problem. That is a problem, but it's not the problem. The problem is that the annulus fibrosis that's here has torn and allowed that to move out. So now what you need to do is the annulus fibrosis needs to heal where that has escaped here. It needs, that hole needs to heal. That's the thing that you need to focus on. And initially it will lay down scar tissue, and that scar tissue will remodel over time. That scar tissue will remodel over time and improve its strength and integrity, and the disc will restore and build its capacity to bear load again. What else we got here? J Manga says, is hip hinge good for a bad SIJ? The only people I think that have an SIJ issue or can have an SIJ issue as a primary issue are the pregnant ladies. If you're not a pregnant lady, your SIJ may well be, firstly, may well not even be an actual issue. Secondly, if it is an issue, it's a downstream issue of the lumbar spine. Everything you're going to do to stabilize an SIJ is exactly the same stuff that you're doing to stabilize the lumbar spine. Fundamentally, you are, when you do exercises that we talk about, rehabilitation, right? We have to understand the level of sophistication we can have as an individual operating on our body. You can't control any of these joints individually. You can't move your left SIJ. It only moves 1 to 2 degrees. It does not move a lot. And you don't have the facility to be able to move just that or stabilize just that. You can stabilize this region. The lumbopelvic region is the best level of understanding that you guys need to be believing you're interfacing in. You're interfacing in the stabilization of this. You can't stabilize this. You can't stabilize this. You can't stabilize this other than by stabilizing this. And that's the beauty of it. It makes everything very, very simple. It means that the person that has the SIJ issue, the person that has the L4-5 disc issue, the person that has the L5-S1 facet joint issue, the person that has the degenerative disc disease, the person that has a spondylolisthesis, all of those people can do the same thing and get better. Why? Because all you can all do is stabilize this. But by stabilizing this, you protect the area so it can go through a healing process. And by applying load to the system, you build its strength, resilience, and load tolerance. Renu says, I'm doing your towel exercise for the neck, lower back. Any other tips, please? If you have a neck issue, they don't have these for the lower back. Like a lot of the back stretches and things you see, they suck. They're not very good, right? But for the neck specifically, the neck cloud, I think it's called a rest cloud. It's like a 20-pound thing. We have one on, we have a video on how to use it, which I would strongly recommend on the YouTube channel. Just type in neck cloud review or something like that and it'll come up. But that is really good for the neck. It's better than the towel for the neck. It just supports the neck a little bit better and supports the natural lordosis a little bit better. And if we've got disc issues and straightening of the cervical spine, those kind of tools are absolutely fantastic. And specifically, we have a specific couple of cases. Actually, we reviewed one a little while ago. Actually, if you're interested with the neck issue, go back to one of our live sessions in early January, which are on the YouTube channel, where we reviewed one of the members who'd been using that to remodel her cervical spine, change the structure of her cervical spine. It is possible, right? I've had 2 occasions now. I was very reluctant to talk about using those devices for remodeling, but it does seem that they work, as is verified by before and after x-rays that I didn't take, right? It's not like I'm there standing making the person in a funny position, right? Important. It's not like I'm being biased. These are done completely independently of anything that, anything that we're doing. Obviously, the people were members, and they were instructed to do that by us, but the results, the evaluation was all done outside. What else have we got here on the comments and questions? What have we got? So just going back through some TikTok. I'll come back to YouTube in a second. Nikki says, working on stability and strengthening Roman chair is my go-to. Go and watch the video. Go and watch the live session that we did earlier this week where we talked specifically about the Roman chair. Not a big fan of them. Yes, you can do stuff with them. Absolutely fantastic. But I just think well, you go and watch the video and I'll explain why. I think the Roman chair is just unnecessary for most people. Submarine says, I'm having back pain. It feels like I slept funky, but hurts. Take a full breath. Don't know where in the back that is. It could be related to the ribs. Rachel says, what's the best exercise for building resilience to strengthen the back? We talk about them all the time, right? Dead bug, marching bridge, squat, hip hinge, step up, single leg hip hinge. Those cover pretty much everything. I'm yet to have someone come back and say, oh, it's missing out on this or that or the other. You've got the primary load bearers in the symmetrical environment, squat and hip hinge. Those are going to be your heavy lifters, literally. You establish good technique in those and you build the load tolerance in this section of the spine. Then you've got your asymmetrical loading exercises, your step up, your single leg hip hinge, which challenge the anti-rotators, as some people call them, the deeper muscles to make sure that we're holding stability, improve your balance coordination. And on all of those, you should be strengthening the spine. Kevin said, can I send you a pic of an MRI for my back? Guys, if you need more support, if you need that kind of support, join the program, right? Send us a DM. We'll send you a link to go and have a look. We do these live sessions to help you guys. But if you do need support, if you have been struggling with your lower back, right, we've got two main resources. Resource number one is free. That's the masterclass, right? It's 80 minutes long. It's on the YouTube channel. It's on the website alongside a detailed article. It's also on the TikTok page, split into two parts. It's in a playlist called Masterclass Playlist or something like that, accessible from the top of the menu item when you're on our profile page. But if you do need more support, check out the actual program. There's a link in the profile page. If you're over on YouTube watching right now, then just send us a post or post a comment, sorry, and we will go through that there. Nat B. Lower back, hip pain, can't flatten my back to the floor after having a baby. Is this fixable? Yes. Yes, I strongly suspect it is. Doing the rehabilitation work. When you've had a baby, I don't know how recent the baby was. Congratulations if it was recent. Congratulations, one could say anyway. So that's awesome. But ladies are often not given anywhere near the support they need to rehabilitate and recover. And even if you are, especially if it's your first child, you're so overwhelmed, right? You're so overwhelmed with everything that you're doing that you often come last, right? And as you find your feet in that scenario over the coming weeks after giving birth and coming months, you can start focusing on yourself a little bit more as best you can. V low, spondy. I'm assuming we mean spondylolisthesis. Any suggestions? Everything we've just been talking about would be helpful for you, right? Learning to stabilize the spine, building strength and stability. Maria Di Antonio has says, are back braces helpful? No, back braces are extremely unhelpful. As you guys have probably noticed, some of you guys will have, some of you guys won't have. Everyone that comes into the chat here, and especially on TikTok, right? The algorithm is definitely doing a good job for you guys. It's finding the right people, right? But you're all coming in, by and large, with two areas of problem. L4-5 and L5-S1. Spondylolisthesis case, for example, just mentioned, probably L4-5 or L5-S1. This area down here, okay? That's where you're coming in. If we think about a brace, how does a brace work? Now, I'm skeptical with regards to braces, period, about the lumbar spine, because you've got so much squishy stuff in the middle that, well, is it even doing anything? But we'll put that criticism to one side for the moment. Assuming you are a skeleton and have 0% body fat and 0% anything, the lowest you're possibly going to get the belt is going to be here, which means we are holding the L4 vertebra. That would be the equivalent, in my opinion, of putting a knee brace, or sorry, an elbow brace around my arm here. It's doing nothing to protect the actual joint. It works by bracing the joint, not the bone. And so we can't even get the brace at the right level. The brace will give you false levels of security about your back. The brace does not at all in any meaningful way stop you bending and rounding the lower back. And therefore the brace, if anything, is a great route to make your back worse. You rely on something that does the engagement for you, so your muscles get weaker. It's not even at the right level. It gives you false senses of confidence. It takes away time you should be spending actually doing the work. And if you're doing a brace to push yourself through, that's the equivalent, I would argue, of just taking painkillers and carrying on doing all the bad stuff. That's fundamentally why back pain goes from a solvable problem. It's always a solvable problem, I would argue. Like, I really would argue that very confidently, right? But it goes from a small problem to a very overwhelming problem because we constantly ignore it and don't do the right things when we should do the right things. And so often people go, when they go through this process, they go, oh man, I realize I just wasn't doing so many right things for my lower back before I even injured it. I wasn't strong, I wasn't healthy, I wasn't well, I wasn't prioritizing looking after, something that I only have one of these. I'm not getting a replacement for this, right? You can get replacement teeth, right? You can get, other things replaced. You've got 2 arms. So if one goes, you still got another one, right? Same thing for the legs, but you don't have a second spine. But people don't do things to, preserve their health. But there's so many examples of that in daily life anyway. Oscar says, hello, Michael. Is it okay for me to do pull-ups at my stage? It's perfectly okay, Oscar. I just personally would prefer to do pull-downs, like lat pull-downs. I have to do pull-ups because I'm using the gym here, and well, you just put on a weighted vest and crack on. But I do think that, like, if you're in a good gym, and Oscar, I'm pretty sure you are from memory, I just use the lat pull-down machine. It's so much more fun. Martin says, question, I've been doing the hip hinges squats, progress from 2 to 70 kilos. Nice. But I'm not doing any pain relieving exercises. Feels like I'm 80% relieved already. Should I start doing pain relief? I don't know what you mean by pain relief exercises. You relieve the pain by building strength so that you're not vulnerable and constantly irritating and injuring the tissues. It might be that we're not doing relief-based practices, right? So we talk about towel decompression. We should be doing those, right? I would suggest, as for a lot of the guys anyway, so Martin might well fall into this category, you build strength well, but then you get to that level where you've got the appropriate levels of strength, but you haven't got the appropriate level of flexibility. So you need to then turn your eyes to your hip mobility. Why do we talk about hip mobility specifically, right? Because hip mobility is good, but people talk about spine flexibility. I need to improve my spine flexibility. Let's look at this here again. Just go back to the x-ray for 1 second. You have absolutely no idea how much this joint moves. Oh, help if I actually turn the thing on. You have no idea how much L5S1 is moving. You have no idea how much L34 is moving. You have no means of measuring how much L12 is moving. So how do you even know your back is not mobile? How do you even know the back doesn't move that much, right? There's not necessarily that much movement. How do you know that this section isn't now hypermobile? You have no mechanism for actually ascertaining anything about the mobility in your lumbar spine meaningfully. You have no idea what the starting position is. If you're starting with a 15-degree curve through the lumbar spine, you're probably not going to have much room to flex more. If you're starting at a 40-degree curve in the lumbar spine, if you bent forwards, you would have lots of room to go forwards. Hopefully this is an example for you guys. It makes a bit of sense, right? A lot of people that have a flattened lumbar curve feel like they don't have any forward flexion. That's because when they're standing upright like this, hopefully this really hits home for some of you guys, right? Maybe explains why you feel like your back's always stiff. When you go to the physio or the osteo or the chiro and they say, oh, look, your back's really stiff, you can't go very far, so just do more forward bending. Well, if my spine when I'm standing upright is here with a normal curve, okay, imagine you've got a body over the top of this, right? I've got a normal curve in the upper position. For me to go from 40 degrees to 0 degrees, I've got all that motion, right? All that motion has happened, okay? So I've moved a lot from the surface. I've gone from here to here, and I haven't moved my hips, right? My hips have stayed where they are. I just kept my pelvis steady and it's just lumbar movement. If, however, you standing upright is this, I don't have much more room to go. These joints are already flexed. It's like going, if my elbow starts out in this position, I don't have much extension to my elbow. But if my elbow's here, I have lots of extension to my elbow, right? So some people get told they have limited flexibility in their lumbar spine, and it turns out they might have a significant reduction in the normal alignment of the lumbar spine. They've got a flat lumbar spine, so their lumbar spine has already used up all of its flexion. They need to get to the point where they actually have a lordosis in their lumbar spine when they're upright. So they have all of this motion to actually use. These are extra layers of sophistication and understanding of the spine. And when we are just used to doing physical examinations and talking about these things, we're missing a whole subterranean layer of understanding of the spine. Whether you do that evaluation with every single patient, whether you guys have had imaging or not. The practitioner, the difference, this is the big difference, why people ask, why is there so much difference in opinion? It's the level of understanding. And a lot of people don't have an appropriate understanding of what's below the surface. They look at the back as just a back. They don't look at it as a spine. They don't understand it at the level of a spine, because the stuff that I've talked about, they're just not aware of those things. And that's why there's difference in the confusion. I don't know how I got onto that tangent, but hopefully it was helpful for some of you guys. Private 986 says, please help. Suffering from a bad L4 disc hernia for a few years. How can I strengthen my spine and core? Exactly what we're talking about. We talk about the 6 exercises, the dead bug, the marching bridge, the squat, the hip hinge, the step up, the single leg hip hinge. If you have been struggling for a long period of time, do check out the website, backinshapeprogram.com. Profile page. Head over to the YouTube channel page. Send us a DM. Whichever is best for you. What else have we got here on the comments? April says, April's replying, giving Anthony a bit of support. Anthony's 10 months post-op, still very weak. I'm losing hope. Anthony, the great thing is, if you feel still very weak, that is, if that's your biggest thing you're observing, you can change that. You start building strength, but you don't feel strengthening. This is an important distinction. I think I only discussed it on a TikTok today. I didn't discuss it on an actual live, on this live. Although we've been going for 50 minutes, so I might have. So I apologize for those of you if this is repetition. There is a huge difference between healing to repair damage and strengthening. And the problem is, for people in Anthony's scenario, I don't know what the history was, right? I have no idea. But I know Anthony, as the archetypal case, has a lower back issue for a long period of time, managed not necessarily so well. We end up having surgery. Then post-surgery, we're not particularly active because we're told not to be, right? And so we've just lost strength. Well, of course, you're going to be weak. You are weak. It's not that you feel weak. You are actually weak. You might well go through a healing process after the surgery. Your body will be, right? But if you are so very weak, you have to understand that the strengthening process is a process that does not happen on its own. You need to drive that process. And if we are starting from a weak position, how we do this really matters, right? The muscles will feel weak and painful because they are weak. They're having to do stuff that they cannot manage, right? If I try and bicep curl a 5 kilo over here, I'm fine, right? If I try and bicep curl this 36 kilo kettlebell, it's not really, it's going to feel weak and sore. And if I try and push it, I'm going to get in a lot of trouble. And unfortunately, some of you guys are at a point where there's not a lot of strength there at all. What do? Oh, you're the only one that can fix that, by the way. You don't need to pay anyone tremendous amounts of money. You just start doing the rehabilitation work, right? I've already told you guys it. Now, if you need more support, more guidance, more structure, yes, there's the program there. And yes, it's paid. But there's also a masterclass, 80 minutes. It's free. It's on the YouTube channel. You just follow that. You build the strength. Some of you guys will be able to do that. And we get people commenting on the YouTube and on TikTok and stuff like that all the time, saying they followed the core 5 or they watched the masterclass and they're doing this, that, and the other. Awesome. Happy days, right? That's why we put it out there. We don't put it out there not to be helpful. It's an 80-minute thing. It's detailed. It tells you what you need to do, right? But some of you do need extra support. And if you need extra support, be honest with yourself. You can do this. You can get your back stronger again, healthier again, everything. The question is, can you on your own, right? Some of you will just need extra help. What else have we got? Yeah, someone said about blocked nerve in the lower back. Yes, that is correct, Jake. If you've got numbness in your index finger and middle fingers and thumb, that's your neck. That's not the lower back. April says, is X-ray useful plus rehab for a pseudo disc at S1, L1 at S1, S2? So we're probably talking about a degree of lumbaralization of the sacrum. Extrusion at L5S1, impingement nerve, L4-5 bulge. It might be interesting, April, to see what I've discussed on the live today, to see the alignment, to see those things. It won't change anything. If it's a pseudo disc, depending on how large or small it is, it's kind of just sitting there not doing too much, generally speaking. And it will most likely be the L5S1 that is actually the main issue. Pseudo discs tend to be protected. It might even be that the pseudo disc is inside the actual sacrum, the S1-2, and the S1-2 actually doesn't even move. And if it doesn't move, it can't really materially be injured because it's got bony struts either side of it. It's not a free floating disc that is doing all of the load compression. It's just kind of like a bit of a, what we say, pseudo disc, a small disc, right? That's not really doing anything. It's just there, right? And so that's probably often those kind of things are a bit more a distraction. Now, it might be a pseudo disc or a disc or a rudimentary disc. That might be a better word, rudimentary disc. That is actually, because of the degree of lumbaralization to the sacrum, it is actually doing a little bit of load bearing. That could be the case. But is the X-ray going to change anything? This is the question, right? And this is the question that critiques of this opposition of this view might have. They say, well, you're going to take an X-ray, which is going to radiate the patient, as we mentioned. It's got a dosage of radiation, right? All medical procedures carry risk, okay? And is that going to change what April, for example, needs to do from the rehabilitation process? No. The MRI doesn't change what you need to do from the rehabilitation process either. Neither does the X-ray. Neither does the other imaging. It doesn't change. If we've got an understanding that we've got an injury to the lumbar spine, we know what's wrong. We have to rebuild resilience of that area. That doesn't change. Now, does the imaging change what you might choose from a surgical standpoint? Yes, it might do, right? I'm not a surgeon, but it might do, right? Oh, actually, do you know what? That disc bulge there, that's not so much, but actually this disc bulge correlates with the symptoms more. And actually, we should get that one. Or maybe this facet joint, or whatever the case may be. What else have we got here? Thank you, Rach, for that comment. April says, I totally understand it won't rehab, but if it can help going forward. I think the biggest help I would suggest, so April said here, right? I'm curious to learn more, or very fascinating. One thing that I can tell you that's been really cool about the way in which we do things now. So if I compare this to before we just had the clinic, right? When we had the clinic in London, those of you that know the story, it's on the About Us page and all that kind of stuff, the background, all that kind of thing, right? When we just had a clinic and didn't have this kind of program, we had a different kind of patients. It was still great, right? Fantastic, but it was different. When we had the program on its own, that was awesome, right? And when we had the program and the clinic here, again, it's awesome, but you're seeing a different kind of patient, because a different kind of patient goes and joins a program, right? But what I would argue is the person that wants to engage in the process is the sorts of people we see now. We don't tend to see, someone's not going to join a program if they're like, I just want you to fix me. But we did used to see those kind of people in clinical practice, and it's just not as enjoyable. You can't pass someone else your back. And so in the individual that is curious, that's interested, that wants to learn and understand their lower back, as many, many, many people do, and we're lucky enough that all of our members tend to fit that bill, right? Because they wouldn't join the program if they didn't, right? The imaging can provide additional understanding of your own body. And in those sorts of scenarios, I'd say that is the value. And you make the decision. Is that valuable for you? If it is, that's great. We can talk about it. We can go through it on a live, for example. That can be really helpful in you understanding your own body. And obviously the way in which we structure the program and the premium members area is that you guys are free to ask, or ask questions. You can ask us about all sorts of stuff, right? You can ask us what the weather is. You can ask us what the lottery numbers are going to be tonight. We may not be so accurate on some of those things, but when it comes to the back stuff, we can really help you guys understand that. And I think someone sharing their images can be really helpful. So if you've got images from your local chiropractor, or your osteopath has sent you for some physio, for some MRIs, or your GP has, and you've got those, you can by all means share them in the members area. We're happy to look at those and talk through those. On those lottery numbers, yeah, I'll try. I'll put some in the group. And you get 300 people, 400 people, 500 people splitting the prize. Private 986 says, I also have numbness. I'm numb in my toe and part of my feet. Is it related to the L4 disc hernia? It could be if it's hitting the right nerve, the right descending nerve roots. BIP Lab says, do you help with the neck as well? Yes, the best thing I would suggest if you're looking for help with the neck specifically is, if you're in the members area, just send us a message, post in the members area, sorry. But we have a detailed podcast. It's actually quite old now. It's maybe a couple of years ago, on whiplash. And it's called Whiplash. That was just for the algorithm, but it talks a lot about the neck anatomy, and it's a good educational tool for the cervical spine. So that would be a good starting place. And again, it's freely available on the website. And then we do also have the neck program as well. But the neck program is a little bit different. That's a bolt-on purchase for premium members. Ordinary people who aren't members of the program can purchase it. But I always say, watch the Whiplash podcast first, get an understanding, and then if you need extra help, then you can go and get the neck program as well. Joe says, should I be starting sooner? I'm 2 weeks post microdiscectomy, not going back to start rehab until week 6. Joe is hitting on a concept that I find deeply frustrating. And I would ask this question of Joe. And Joe, if you're still live, answer this one quickly in the comments if you could, and we'll kind of start wrapping up with this topic. Did you leave the hospital? Did you get dressed on your own? Did you get out of the hospital bed? And did you get sent home in an ambulance on a stretcher? Or did you have to get in a car and make your own way home? Do you have stairs in the house? Does your surgeon know this? Do you go up and down the stairs in the house? And are you currently getting in and out of bed on your own? I'll give you a few moments to answer those questions, Joe. Just briefly, you could say something like yes to all of those or something like that, right? And then I'll come back to that particular comment from Joe White. Let me just make a note so I don't forget. Yes to all. Okay, yes to all. Yes to all. The answer is always yes to all, guys. When you've had back surgery, Joe has just had a surgery of microdiscectomy at L5S1. He got out of the hospital of his own steam. What is getting out of the bed, hospital bed, involving? Bending, twisting, moving the spine. Joe, were you advised on how to get out of the bed, or did you just do the best you could and off we go, right? Did you get advised on how to move your spine when you were getting into the car? Did you get advised on how to use your spine when you're going up the stairs one at a time? Did you get advised on how to get your shoes and socks on? Just don't do anything that hurts your back too much, and don't bend, don't twist, and don't lift. The guidance is terrible, absolutely terrible. And so if Joe had turned around and said to the surgeon, hey, doc, do you reckon I could do some squats today? He's going to fall off his chair probably and say, what on earth are you thinking? You've just had back surgery. Why on earth would you do squats? Very reasonable response if you are completely assuming that the patient has no reasoned logic. But that's not true at all, right? You are not going to go, Joe is not at all thinking of going into the gym and doing squats on a barbell. But would it be a good idea, considering Joe is going to have to get out of bed every day, considering Joe has already been cleared to do all of those things to get home, if Joe spent some time at home holding onto the other half's hands and practicing doing a squat, okay, I think I get my posture good, I engage the core here, get my feet underneath me, hold onto the other half's hands, and up we come. And then we go down again. And up we come. Okay, I'm practicing here, practice. Okay, let's do the hip hinge, right? We're going to get into the hip hinge position. Would it be, get a chair right in front of me so I'm safe, not a wheelie chair, right? And then go down, try and get the hip hinge, looking in the mirror, right? Hip hinge. Oh, that's a squat. No, hip hinge. Okay, good. Hip hinge, hip hinge. Good, right? Lying on the bed doing the core engagement. Would it be a good idea if Joe just gets left to his own devices doing a bunch of random stuff every day for the next 6 weeks before starting physio? Or would it be a good idea if he started that even arguably under the supervision of intelligent and informed hospital staff before he leaves? Wouldn't that be a good idea if you left, if you part of your surgery was the day after, you go through with the physiotherapist or the person there, or even the surgeon, but maybe he's a bit busy doing other stuff. I don't know, right? We could question that all we want. And they actually went through some fundamental movements and skills. Wouldn't it be even better if you did that before you had the surgery, right? If you said point blank to the surgeon, can I do squats? They're going to say no. But if you said to the surgeon, am I able to get out of the hospital bed and go home? Am I able to get into the car? He's going to look at you funny. He's going to say, well, how on earth do you think you're going to get home, mate? Right? Okay. See, so then you say to the surgeon, you specifically, you say, considering the fact that you're happy for me to get out of my bed and get out of the car and get out of this bed right now, wouldn't it be a good idea if I learned a little bit more on how to actually do that in a way that is more optimal to the spine? Is this going to be a good idea if I do that every time I get out? Or is it better if I do something that looks like this? And he'll probably go, doing something that looks like that would be a little bit better. You look a bit more controlled, Joe. So, well, then wouldn't it be good, considering I'm just sat at home twiddling my thumbs, if I had something to do, right? Sorry to be so sarcastic, but it's so frustrating because I know the answer when I asked the question. When I said to Joe, are you doing X, Y, and Z? Right? But people, unfortunately, are sent home with the fear of God put in them that they've just had a spine surgery and they don't want to have another one. And they're given no guidance other than don't do too much stuff. And maybe there's a little bit more than that, but you get the idea. And you go and do your physio in 6 weeks' time. It's just not appropriate. The person's probably had time off work. They've got a great opportunity to learn a little bit more about the spine, about how it works, about their health, to practice these engagements, these simple skills that are going to mean that each and every passing day, they are more technically proficient at supporting and controlling their lumbar spine so they can optimize the likelihood of having a successful surgery that allows them to get back to doing what they want to do. Because the surgery is not the end. The surgery might remove this little bit of disc, but this thing needs to heal. This thing needs to heal. And you need to support that healing process as best you can. So, Joe, I hope that helps. There's only so many times you can go through that thinking on my end, right? And not get animated about it. Because it's shocking. It is so shocking that you guys get sent home and it's just like, yeah, your physio will be in 6 weeks. We have to ask the question, is that because that's what the system is set up to do? Or is that is that something else, right? Is that just the convenience, right? Yeah, well, it's going to take a bit of time in the waiting list as long as do it in 6 weeks' time, right? I always remember, when we had our first child, this was back in 2022, Lara was getting tested for iron, and the levels were such and such, right? The recommended levels. If you were below this level, then you got recommended iron, okay? When we went back for the first, they said the guidelines have changed, and now if you're below this level, you should be recommended iron, right? And so you're like, okay, blah, blah, blah. We fixed it. We just did something crazy. We just ate meat, got the levels tested again, and lo and behold, oh, wow, her iron levels were fine and normal. She hadn't been eating so well because she has a bit of, or usually gets a little bit of sickness in the first parts of pregnancy. When we went back for the second baby, they said, oh yeah, those guidelines were scrapped. We go, okay, why is that? Probably, I'm being cynical here, because they realized it was costing too much. So either the research in the first instance, in this particular example, to inform the protocol, and I am speaking with limited knowledge, but just as an observer, if the first protocol that we should prescribe these ladies iron if they are below a threshold that has been raised, or lowered, sorry, or raised, sorry, if that was made because it was in the interest of the health of the individual, then why are we changing it? The only explanation 2 years later is that it's because it costs too much. And so how much of the recommendations, like Joe, like many of you guys that have had back surgery, to do the physio in 6 weeks, how much of that is because of constraints that are not related to your health and well-being? Because I would argue you've got nothing else to do for 6 weeks. You've probably taken time off work. What better use of your time than learning some of these things? And unfortunately, we do live in an economic environment, right? Someone's got to do it, right? And the physios need to be paid by someone, right? And because they need money to put food on their table, right? So someone's got to pay. But conflating the fact that some of these things are financially driven decisions and thinking they're actually for our health. Oh, it's done that way 6 weeks because of that. What's the explanation? And I think it's very difficult to suggest that explanation, the explanation for having your support, your actual rehabilitation support, 6 weeks delayed, I think that's very questionable. I think that's very questionable. The rationale there being for the better of your health rather than for other reasons. April says, I wish Buckinghamshire was NHS approved. Yeah. Rachel says, this is so true. April, that was I don't know if you've seen on the website in the features section. We had Annie was one of the GPs that was a member of the program early on, a couple of years back. She's still with us actually, but her scenario was because she was a GP, she literally was doing the program but could not recommend the program to patients because of the constraints of being a GP in the NHS. You can't recommend those things. So that's an interesting situation for her to be in. Rach says, this is so true. I was told to rest until my pain reduced, even without surgery. Yeah. So what's happening is you're resting. Most people do not have sufficient muscle mass. Those that do, right, they're losing something, a real asset that they've built, which is so helpful, and then they lose it, right? That's even worse, right? But for most people, this may not be relevant to Rachel, but most people do not have sufficient muscle mass. So when you are told to rest for extended periods, you lose what little you had. Yes, healing is going to take place in that time. But then once healing has taken place, you are now more vulnerable because you have no support, no coordination. You've lost significant muscle mass. So then you start abusing the lower back again and boom, re-injure, 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 re-injure. It's a problem. What else have we got here? After the tear heals, would you not be worried as you would still have a weakened degenerate disc? No, you wouldn't. There is a time frame where you've got a weakened degenerate disc. And do you know how weak or degenerate it is? With your squats and hip hinges. This is one of the important benefits of strength training as part of your rehabilitative process. You know very clearly that the disc was injured, healed, maybe we just had surgery, whatever, and it could not bear 5 kilos on a squat. If you're now doing 50 kilos on a squat, aggravation free, without any trouble, with correct form, the disc is stronger. And 40 kilos might be the heaviest squat you've ever done in your life. For some people, it is. So verifiably, we can say that that disc is bearing more load than it ever has in your life in the resistance training environment. And it's a disc that's had a herniation on it. For the vast majority of adults, I do believe this, and I discuss why on one of the strengthening podcasts. Even after you've had your herniated disc, that is often, in many cases, if you do rehab properly, you will be stronger than you ever have been before. if you do the rehabilitation strong, you'll be more resilient than you ever have been before. Why? Because you never put any effort into actually supporting the health of the body. Yes, there are many of you that doesn't apply to, right? There are many of you that do this stuff, and you've been unlucky, and that's fine. That's a different conversation. But by and large, considering the fact that 90% of the population do not do meaningful long-term strength training, as per a research study that we referenced a couple months back in a podcast of 250,000 adults in the UK, over 90%, men and women, do not do this. So there's every chance that you can be stronger than you were, and specifically the disc stronger than it was before you've had your surgery, or before you've had your injury, afterwards. How would lumbar spine straightening be treated? How do you take the curve better than it is? The main way is just using a Denerol. It's super easy. Takes time, but it's super easy. Guys, I've overrun, as per usual. Hopefully this has been a helpful one for you guys. Hopefully it has been helpful. Hopefully it's been insightful. Hopefully some of you guys have found it helpful sharing the x-rays and going through those on the screen. If you've got any other questions and you're watching this on repeat, you can always post down in the comments. We do read and reply to all of those. Guys, if you're on the mailing list, the email list, keep an eye out for an email later this afternoon, some exciting news. There will be a couple of emails to go out over the weekend, just with the launch of a new thing. So keep an eye out for that. It should be really cool. And we will see you guys next week on the live stream. We should be doing Monday, Wednesday, Friday next week on the lives, lunchtime UK time-ish, maybe 1 in the afternoon on 1 or 2 of those. So keep an eye out. And guys, those of you in the members area, if you need more support, more help, more guidance, please do a post in there. Upload your videos, post your comments, challenges. Ask yourself this question going into the weekend, especially if you're one of the members, right? If you're currently in phase 1, why are you not in phase 2? If you're currently in phase 2, why are you not in phase 3? If you're currently using 5 kilos on your squat or hip hinge, why are you not using 6 or 7? Ask that question. There might be a valid answer, but sometimes there's not. So ask that question. Let us know in the members area what the answer was, right, when you asked yourself that question, and we'll help make sure you're going in the right direction. So thanks to all of you guys that joined. Thanks to all of you that asked questions, comments, etc. And see you guys next time. Bye-bye.